Hello, my name is Michelle Sondermann, and I'm a Bachelor of Nursing student at Mercy College of Nursing through Southwest Baptist University. We have currently been discussing evidence-based research, and in this presentation, I will discuss the research that I have found on the needs for accurate weight measurements of heart failure patients. To start off, heart failure is a chronic condition in which the heart is unable to pump enough blood into circulation to meet the body's needs. With chronic conditions like congestive heart failure, fluid is shifted in the body very easily. A rapid weight gain could mean a serious change in disease condition. Cardiac patients are a specific group of patients that must pay very close attention to their body weight measurements. Albert explains, investigators defined clinical exacerbation of heart failure as the occurrence of at least two of the following: new or worsening edema, increased body weight, worsened dyspnea, and several others, all of which are indications of hypervolemia. This indicates that we should not only be educating our patients on how to correctly weigh themselves at home, but other signs and symptoms that could indicate fluid retention as well. The only way that we can know that these patients are possibly retaining fluid is by a daily weight measurement, but for many institutions, this process is often inaccurate. Curtis and others explain that assessing whether a patient is losing excess fluid can be accomplished with strict surveillance of daily weights, but it was identified that the unit's process needed improvement. It is evident that inaccurate weight measurements can affect many outcomes for cardiac patients, and implementing a standard procedure for daily weights could improve disease management at home and in the hospitalized. You or a loved one may have or know someone else that has been diagnosed with congestive heart failure. Cardiac patients are on many different medications to control their symptoms, and physicians rely on accurate weight measurements to prescribe the correct doses of medication to manage their chronic disease processes. When a patient's weight measurement is consistently inaccurate, it can lead to poor outcomes of their disease management, and having a standard procedure for daily weight measurements could prevent these medication errors. As Curtis and others explain, utilizing routine quality checks and providing the staff with the resources they need has enabled the unit to become more efficient and allows physicians to make calculated decisions based on an accurate patient weight. To guide my research, I have created a PICOT statement to guide my research. For cardiac-specific patients, does a standard procedure for accurate weight measurement compared to a patient-reported weight measurement impact the outcomes of their disease management over a 3-month period? The main idea here is that should there be a standard procedure across the board for how patients weigh themselves at home and how it is done in the hospital? Does there need to be a daily weight, or can we weigh these patients every 3 days? Are we educating our patients about the signs and symptoms of weight gain and weight loss and how this affects their disease process? This will all be further discussed in my presentation. This is an outline describing my search for articles chosen. The database that I used was Medline with full text. The terms and Boolean operators used were heart failure and weight. I only chose 2 terms with my Boolean operators because I had trouble finding specific article titles with my terms that actually related to my search. By simplifying and broadening my terms, I was able to find studies that included my PICOT statement that was tied in with other major topic of research as well. The main topic I found was related to diuretic use, which is the main medication that heart failure patients use to control their fluid status. But my PICOT question does not technically focus on this, so I had to put a little bit more time into my research. I narrowed my terms with the categories of date, source, major heading, publication, and age. I wanted to focus on the mid-aged and elderly because this is about the time frame that most become diagnosed with heart failure and need to focus on management. Keeping my date within the last 10 years gives me relevant and recent research. I chose the major headings: heart failure, hospitalization, self-care, weight loss, body weight, body mass index, diuretics, and fluoride. These kept me focused on my main topic of heart failure and importance of weight management. I then finalized my narrowing with publication of a large amount of publications, specifically related to heart failure, heart health, and cardiovascular disorders. Finally, I chose my 5 articles, making sure to have a different type of trial, even though some use the same methods for grouping their clients. These are the 5 articles that I have chosen. Self-reported recall and daily recorded measures of weight monitoring adherence, associations with heart failure-related hospitalizations, was chosen because it concludes that there are fewer heart failure-related hospitalizations when patients are taught to correctly weigh and record themselves, showing better disease management overall. Second, can individualized weight monitoring using the HeartPhone algorithm improve sensitivity for clinical deterioration of heart failure? Was chosen because it explains the need to better monitor heart failure patients' weight and introduces a new telemonitor for bettering weight monitoring in these patients. Third, patient-reported selective adherence to heart failure self-care recommendations, a prospective cohort study, was chosen because it represents how little heart failure patients participate in self-care and the amount of education they receive for it, including weight monitoring. Fourth, effects of a home-based activation intervention on self-management adherence and readmission in rural heart failure patients, a patch randomized control trial, was chosen because it shows the need to intervene in patients' self-management techniques in order to decrease their rate of rehospitalization. And lastly, body weight change during and after hospitalization for acute heart failure, patient characteristics, markers of congestion, and outcomes, findings from ASCEND heart failure, was chosen because it compared body weight changes during hospitalization and post-discharge, showing that patients had an increase in body weight post-discharge, worsening their overall disease management. There are several similarities within these articles, mainly relating to the fact that better adherence to weight monitoring showed a decrease in rehospitalization for acute heart failure exacerbations. To point out a few, Jones and others found that self-reported recall of weight monitoring was not associated with fewer rehospitalizations, but when patients diary-reported their weight management, 80% of the time, there was an association with fewer rehospitalizations. Young and others saw the same results with self-management adherence. Or when Ledwidge and others shows that through the use of their new device, conventional guidelines for weight monitoring are inadequate for heart failure patients. To compare this to my PICOT statement, self-reported weight measurements are correlated with increased hospitalizations, and a standard weight method should be implemented for better disease management. There are a few inconsistencies with my PICOT statement. Jones and others found that there was no difference in rates of rehospitalization between patients who self-reported their daily weight measurements and those who self-reported less often than daily weight measurements, whereas Marty and others found that good adherence with self-care was associated with fewer hospitalizations and hospitalized days per 100 person years. To compare this to my PICOT statement, with proper teaching, patients can self-monitor their weight accurately. However, most patients are not taught accurately, leading to poor disease management. The main gaps seen were with knowledge and patient engagement. As Young and others explain, to address the knowledge gap, we conducted a randomized control trial to test an activation-enhancing intervention to improve self-monitoring adherence. Patient activation is defined by Hibbard as the person's readiness, willingness, and ability to manage his/her own health and healthcare. Like stated before, if patients do not understand the importance of their weight monitoring and management, they are less likely to adhere to a routine of it. Or when Jones and others speculated that patients' completion of their weight monitoring diaries was a direct reflection of their engagement with their self-care. To compare this to my PICOT statement, the knowledge gap is the largest gap in each of my 5 articles chosen. Like stated in previous slides, patients are uneducated about the effects of not adhering to a self-weight monitoring program, therefore they lack education about its necessity. The main limitations seen with these articles were that results lacked generalizability. Like Ledwidge and others state, the data were evaluated in a predefined high-risk heart failure cohort, and the results obtained here cannot be directly applied to lower-risk heart failure patients. Or Marty and others found that there might possibly be a difference in education with a community clinic versus acute care hospitals. To compare this to my PICOT statement, the severity of the patient when studying this chronic disease process is the tricky part. Proper weight measurements still matter with heart failure patients regardless of the severity of the patient because they are all at risk for fluid volume excess. To conclude this presentation, there is evidence to support implementing a standard procedure for accurate weight measurement to improve outcomes for heart failure disease management, although there are no current specific guidelines for weight measurement. Support has been shown through prospective cohort studies, randomized control trials, and randomized double-blinded control trial studies. Marty and others explain patient-reported adherence with heart failure self-recommendations is alarmingly low and selective. Patients' adherence to self-care recommendations are very low, and patients can be selective in which recommendations they choose to follow. Implementing a guideline for all heart failure patients to follow will result in better disease management and can decrease the amount of errors that physicians can possibly make in regards to medication dose prescriptions. Granted, just because there is a guideline does not mean that all patients and healthcare providers will follow it, but at least there will be a guideline to follow when in doubt and for all patients who care it to be compliant with their disease management.